Good morning, everyone. My name is Waad Ahmed, and I'm presenting from Ireland, Dublin. I'm representing the vascular department at Beaumont Hospital. I'm going today to be presenting about the targeted abdominal aortic aneurysm screening in a high-volume tertiary vascular center, which is a research that we undertook in 2023, which was quite interesting, and we were able to present it and publish it as well in the Irish Journal of Medical Sciences. So throughout this presentation, we're going to go through a number of introduction. We're going through the methodology behind our research, the results that we were able to come back with. We're going to discuss these results that were quite surprising to us and what we were able to conclude from these results. So to begin with, abdominal aortic aneurysm is a very common vascular pathology. It is defined as the dilatation of the aortic diameter, with the diameter going more than 3 centimeters. It's quite a very common presentation to the vascular clinics and to emergencies as well, where patients usually present asymptomatically for screening and surveillance to the OPD clinics. And if they become symptomatic, presenting with back pain, abdominal pain, they present either to the clinics as well, where they are actually admitted, or they're referred to the emergency department for further workup and imaging modalities, or they can present with a ruptured abdominal aortic aneurysm, which is a top emergency condition that have to be managed as soon as possible. The majority of the abdominal aortic aneurysm, as previously described, they've been presenting asymptomatically. So usually they are caught incidentally on other imaging, abdominal imaging for other indications. For example, a CT, abdomen pelvis, an ultrasound, and then from there they'll be referred to the vascular OPD patients, depending on the size, where usually if the size threshold for males is 5 centimeters, and then they are fit to be undergoing a surgical intervention, while in females it's 5.5 centimeters. And then according to the patient's age, his status, his comorbidities, the type of intervention, surgical intervention, will be tailored to the patient, whether it's endovascular intervention or an open repair. Given that they present incidentally and asymptomatically, many of these abdominal aortic aneurysms are being lost and not being picked up if they did not undergo any kind of scanning or imaging before. Therefore, in some countries such as the UK and Sweden, they've actually operated a national screening program undergone all around the country in order to pick up these abdominal aortic aneurysm, where every patient, every male above the age of 65 is being screened for abdominal aortic aneurysm, similar to other pathologies or diseases such as cervical cancer and as such. And they have found that actually there is some reduction in abdominal aortic aneurysm mortality associated with that. So we were able to undergo this first cycle audit and research in order to determine the pickup rate of abdominal aortic aneurysm in our high volume tertiary vascular center in Ireland, and using a very selective screening, which is based on an ad hoc basis. And we have been able to find out patients with pathology and been followed up with the outcomes up to date. So our research involved a retrospective review of all of the screening duplexes, which has been performed in the vascular lab after being referred to Beaumont Hospital during 2020. We included all patients who have actually been screened for abdominal aortic aneurysm, and we were able to extract that data from the vascular lab numbers. We excluded patients who already had known abdominal aortic aneurysms, which had been identified previously on a CT scan, cross-sectional imaging, and yet to enter into the surveillance, or patients who have been already in the surveillance were not included in this criteria. We then looked at the duplex orders themselves We checked what is the indication behind these imaging, whether it's a vascular path patients, the age, family history, and as such. And we looked back at the clinic letters and further imaging that has been done in McKesson. We looked at the patient demographics, at the presence and the size of the abdominal aortic aneurysm, and the surveillance after the AAA was got, and the reasons of delayed was also all mentioned. We also looked as well, because it was the year of COVID, so we also compared if 2021 and 2020, if there is any change in the number of abdominal aortic aneurysm screening duplexes done, and there was no difference between the two. Thereby, we were able to conclude that there was no difference affected by the COVID. These are some of the results that we were able to look at. So when we looked at the indications for the AAA screening, we found that most of these patients have actually undergone or had the duplex scan for atherosclerotic risk cases. So vascular patients are comorbid patients. So most of them are hypertensive, diabetics, have previous history of stroke, MI, stenting. Therefore, most of these patients, when they present to a vascular outpatient clinic, they've been screened, and this has been represented 65.5% of the indications for the screening duplex. 14% had a potential abdominal aortic aneurysm and other imaging modalities such as X-rays or ultrasounds. 11.5% had a family history, and as known that one of the risk factors of development of AAA is family history, as is very common in males of similar family. 8.5% had venous disease and were screened for that, and a smaller percentage had suspicious examination, clinical examination, which prompted the physician to screen the patient for abdominal aortic aneurysm. The results were very astonishing for us, as we found that 11%, representing 22 out of the total number of 198 screening duplexes in 2020 were actually positive for abdominal aortic aneurysm, having a size between more than 3 centimeter in size abdominal aortic aneurysm. 12% were ectatic, with a size of 2 to 3 centimeter, while 75.5% had a normal abdominal aortic aneurysm. This percentage of 11% represents a very high pickup rate, especially for AAA, especially in the absence of a national screening program. When we compare this to UK, they have a national pickup rate of 1.65%, and this have actually prompted the NHS to actually screen and promote for a national screening program for all high-risk individuals. So when we compare this to our high-volume vascular center, 11% represented a very high pickup rate. Although the sample size is small and it's a limited number of patients in comparison to other hospitals and nationally, this also gives us and reflects that there is a very high pickup rate of AAA. So out of the 198 screening duplexes that we found 22 patients with abdominal aortic aneurysm, and they have been incidentally found. 15% were 15 of these 22 patients were male, representing 68.1%, which is quite common, and 7 were female. 15 had an abdominal aortic aneurysm between 3 to 3.9 centimeter, 5 between 4 to 4.9 centimeter, and 2 patients had more than 5 centimeter aneurysm, which then were being followed up to check what kind of surgical intervention they would require. Up to date, only 3 patients of these have actually undergone an elective EVAR, and only one of them had actually passed away for non-vascular causes. When we looked at all these total numbers in 2020, we did not note any drop-off during the COVID pandemic, as we mentioned before. especially when we compare it to the 2021 and 2019, where there was a total number of 194 scans have been performed. This audit have actually identified a very high pickup rate of 11.1%, demonstrating a very strong clinical need for a focused screening, especially among high-risk vascular patients and vascular path. When we also looked at it from a contemporary literature, which have suggested the cost of managing a ruptured abdominal aortic aneurysm was 23,000 euros per patient. And this have actually led us to think that being able to pick up these abdominal aortic aneurysm at a very earlier stage, before they rupture, before they present very unwell to the emergency department, does make a very huge difference. Therefore, our research was able to provide a very valuable insight into the outcome of AAA screening, especially in our hospital, Beaumont Hospital. And there have been collaboration as well as has been done between different departments and the vascular lab in order to gain more collective dedication to advance the vascular health in our hospital. So all in all, to conclude, our audit was able to identify 11.1% prevalence of a new AAA among vascular surgery outpatients, which has been referred opportunistically for screening duplex. So therefore, there is a very strong clinical need for formalizing a local selective screening protocol, either among vascular path before they're being referred from the GPs. And this will also encourage a more national and widespread screening service, which is already being studied now and has been researched by other vascular trainees as well. I'm very happy to take any questions if needed. Thank you for listening to my talk.